to Australia. He did a neuroradiology fellowship under the auspices of the Diagnostic and Interventional Neuro Service in Western Australia. He's been working for Perth Radiology Clinic since 2000, and he's a partner there. He's lectured nationally and internationally, and he's published various articles. He's also an examiner for the college. And outside of radiology, he has 2 girls. His passions are rugby, which he's done for 40 years. And with that, I'll hand over to Gavin.
Thank you once again. Thank you for inviting me. We've had a great time since we came. These things are always hard for me because invariably I'll end up following Andy, which I guess is appropriate because almost everything I know about ENT has been taught to me by Andy. And so publicly once again I'd like to acknowledge that and thank him. To make it harder, they usually give me some obscure subjects such as the Petrous apex, which is a hard subject, but hopefully I can make it a bit easier. And it's actually quite an important subject because the Petrous apex is a complex but importantly clinically inaccessible part of the skull base. And being clinically inaccessible, it makes radiology all the more important. So it's critical that we get it right when we look at Petrous apex lesions, which are usually discovered incidentally or during the evaluation of cranial nerve palsies. I don't want to label anatomy, but I do want to highlight two important things. The first are the relations of the apex, and the second is its pneumatization. The relations are important for 3 reasons. Firstly, they can be compromised by Petrous apex lesions, and I've already alluded to cranial nerve palsy, so they're pretty much the most sensitive structures around there. The second reason relations are important is they can be obviously injured at surgery. And lastly, from our point of view, they can give rise to lesions that may affect the apex, and that's particularly true of the neoplasms. And so the important relations, by far the most important, are the neurovascular structures, which include cranial nerve 5, and you can see it crosses the Petrous apex to enter Meckel's cave where it divides into its branches. More medially, and I hope it projects, the 6th nerve, you can see just entering Dorello's canal, and posterior inferior 7th and 8th nerves, less involved by Petrous apex lesions, but occasionally can be. Of the vascular lesions, the most important is the Petrous carotid, which is in constant contact with the apex throughout its length, and you can see both in its horizontal portion and in its vertical portion, it is in contact with the bony aspects of the apex. Posterior inferiorly, you've got the jugular fossa, which drains both superior and inferior petrosal sinuses. And although the neurovascular structures get the most airtime, there are other structures which we should be aware of because of what I've said. They may give rise to lesions that involve the apex, and I will come to that. Most importantly, the skull base sutures, the petrooccipital petroclinoid suture, excuse me, which gives rise to the chondroid lesions. More medially, the clivus, which gives rise to the chordomas, and anterosuperiorly, the Meckel's cave, which gives rise to the Keffler-seals of the apex. The second component I want to discuss of the anatomy is the pneumatization, and that's important once again for 2 reasons. Firstly, asymmetrical pneumatization can give a complicated or confusing radiological appearance. And secondly, probably more importantly, the vast majority of the lesions that involve the apex itself arise so because of obstructed air cells. So from an anatomical point of view, in 60% of cases, the apex contains marrow, but up to 1/3 of people, 33%, have a pneumatized apex, and only 7% are they sclerotic. The pneumatization results from extension of air cells that communicate with the mastoid or the middle ear, and the whole reason for even discussing this, the most important is that it's asymmetrical in 5 to 10% of people. So you do get asymmetrical pneumatization, which is obviously relevant to us. So from what I've said, if you look at the anatomy, the apex is a hostile place. It's a place that the surgeon doesn't really want to go to unless they have to. I sort of, it's a bit akin to playing New Zealand in the last World Cup. You only really go there if you have to. And that's pretty rich coming from a South African Australian. But anyway, from our point of view, we have to get it right, because the last thing we want to do is send a surgeon in if they don't need to. So the starting point and the most important point is probably to differentiate surgical lesions from the so-called leave me alone, or lesions that don't need treatment. Having decided that it does need treatment, and they will need treatment because these lesions tend to be expansile, and as we've already seen, they're sort of important structures around there. So generally, they do, if you find a lesion that is expanding, getting bigger, most surgeons will consider at least looking at it, if not operate on it. Once we decide it's one of them, we really need to characterize them, and that's really what I want to discuss today: is how do we characterize, how do we decide what is what. And then it's always good to give the surgeons a bit more information, determine the extent of the lesion as well as its relation to involvement of those important surrounding structures. I've never found a good way of actually characterizing Petrous apex lesions. Some people talk about cystic or solid lesions. Other people talk about malignant or benign. Other people talk about aggressive, non-aggressive. And then most people default to the surgical sieve, which is not a bad fallback. This is a homegrown one, and it's probably as imperfect as the others, but I think it works quite well, and it's not as daunting as it first looks, because if you look at the list, the first point, as I've already said, is decide is it surgical or non-surgical, and that's a really easy differentiation, which I'll show you. Coming down to the bottom, vascular lesion is really talking about Petrous apex carotid aneurysm, which is more about awareness than complex diagnostic imaging findings. Bone displays are similar. They look like bone displays. They're easy to diagnose. And infection I've included, but it's a totally different subject. Infection is basically imaging to confirm a clinical suspicion. The rest are discovered incidentally, and we're trying to give it a differential. Infection is basically, we think there's apical infection, let's prove it. So, which brings us back to two points. I can't find the pointer, but the first one, there are two large groups: the expansile cyst-like lesions, and then there's a second group of solid lesions. And they are also quite easily differentiated. In broad terms, the expansile lesions are centered on the apex. They result from apical air obstruction, and they are cyst-like, do not enhance. Whereas the solid lesions tend to arise outside of the apex, and really what we're talking about are neoplasms. The problem is, and I'll show this in my sinus talk, is that completely different entities can look virtually identical. So as radiologists, really what we're looking for is subtleties, and that's what I want to show in the talk, is the subtleties on how to differentiate the different entities. So starting at the beginning, and I make no apologies for emphasizing this, we have to decide what is important, what is not important. In other words, what is a leave me alone lesion? And the two leave me alone lesions are asymmetrical fatty marrow and trapped fluid. The fatty marrow I've already alluded to in that 5 to 10% people have pneumatized asymmetrical apices. And to the uninitiated, the fat in the marrow on the other side could be confused for tumor, in particular cholesterol granuloma. So it's not the pneumatized side, it's the other side that on T1 weighted imaging is bright, and people sometimes confuse that for tumor. The differentiation from normal fat is easy, and the most important factor about all these entities is that the apex, the affected apex, is not expanded, it is not destroyed, and there's no enhancement. To make it even easier, obviously the signal is going to follow fat on all sequences, and you can see the T1, T2, T1 sequences, and if there's any doubt, just employ MR with a fat saturated sequence. But it's generally, in the modern world, this used to be more of a problem, I think, a few years ago, but certainly modern MR imaging and greater awareness, it's not so much a problem anymore. But to ram home the important bits, for asymmetrical fatty marrow, there's no expansion, there's no destruction, and there's no enhancement. Remember, it follows fat on all sequences and suppresses on the fat saturation sequencing. Trapped fluid, occasionally fluid may be trapped in the apex. That is usually following otitis media. By the time we see it, the otitis media is resolved, patient is asymptomatic, and the fluid in the apex is sterile, and it's trapped there because the communication between the middle ear and or the mastoid has become obstructed, but everything has resolved. Once again, to differentiate that from any other important entity, remember there is no expansion, there's no destruction, and there's no enhancement. And those are really the clues. The MR features can be a little tricky because obviously the T1 protein content can influence the T1 signal. But remember, the T2 will be fluid signal. And the key with all of this is there's no enhancement, but more importantly, no expansion or destruction. And this just highlights how the T1 signal can occasionally be slightly bright. But once again, no expansion, no destruction, no enhancement, and it follows fluid on all sequences. So the leave me alone lesions are easy. When you look at the apex, is it expanded? Is it destructed? Does the entity enhance? And more importantly, does it follow normal fat or fluid signal on all sequences? That then brings us to the pathology. And probably the one that we encounter the most, and although when you see a talk like this, it seems like these things are common. These are all rare entities. But the one which we encounter the most are probably the expansile cyst-like lesions. And as I already said, these arise from obstruction of Petrous apex air cells, and then you get the formation of expansile entities. Because they arise from apical air cells, they are centered on the apex. And that's a really useful imaging tool. And they include the entities of cholesterol granuloma, cholesteotoma, mucocele, and I've included cephalocele, which is slightly different from the others and arises outside the apex, but it has a similar appearance. It is expansile, it is cyst-like, so much so that it's previously been referred to as arachnoid cyst of the apex. And so it's not quite part of this group, but close enough. By far the commonest is the cholesterol granuloma. It typically occurs in patients with pneumatized Petrous apices. So often you see a big lesion on one side and a well, or certainly well pneumatized apex on the other side as well, but not always the case. There are lots of theories as to how it arises, and most of them are variations of obstructed air cells, bleeding into the apex and foreign body reaction. But whatever the theory is, the imaging appearance is the same. On CT, they're smooth, they're expansile, they are isodense to CSF. The contralateral apex is often highly pneumatized. And remember, they are centered on the apex, but the diagnostic differentiators are that they are T1 and T2 hyperintense. So if you remember nothing else about cholesterol granulomas, and I'm sure everyone knows this about cholesterol granulomas, they are both T1, T2 hyperintense, and they don't enhance. And here you can see cystic, well-defined, non-specific, CSF density on CT, very bright, T1, T2 on MR, and this case was given to me by Andy. T1, T2 bright. And that's really all we need to remember really about cholesterol granulomas is they are T1 and T2 hyperintense, they don't enhance, and occasionally you have a highly pneumatized apex on the contralateral side. Cholesteotomas are the big one to differentiate from cholesterol granulomas, and cholesteotomas of the apex can either be congenital or acquired. They usually arise from aberrant rest of embryological epithelial cells within the apex, and they form these cysts which are lined by stratified squamous epithelium and contain desquamated keratin. And that obviously gives it the imaging features. Once again, CT not so good. CT is more about identifying these lesions with characterizing by MR. So CT non-specific expansile lesion. The MR features are different to the cholesterol granuloma in that they're T1 hypointense, T2 hyper, mildly hyper, sometimes a bit variable, but hyperintense. Once again, don't enhance, and the key differentiator is that they restrict with diffusion weighted imaging. So T1 hypo, T2 hyper, and the key is the diffusion restriction. So the differentiating feature for the cholesteotoma is the diffusion restriction. The others just add a little bit of weight to your diagnostic confidence, and they are hypointense on T1, hyperintense on T2. Once again, don't enhance. And remember, just like all the lesions that arise from obstruction, they are centered on the apex. The mucocele, fortunately, very rare because they actually are quite hard to diagnose. But mucoceles in the apex occur just like mucoceles elsewhere. You get an obstructed air cells, continued secretion into the air cell, and you form this expansile cystic lesion filled with secretions. But the bottom line is mucocele is a bag of fluid centered on the apex because it's obstructed. The differentiating feature and the diagnostic problem comes in differentiating trapped fluid from mucocele. But the mucocele is expansile and destructive. But in the early mucocele can be really difficult. The bottom line, It has non-specific C2 features, and it has features consistent with fluid. So T2 hyperintense, T1 hyperintense, but remember the protein content can make it variable. Just like all the others in the group, it doesn't enhance. That's what it looks like, and you could argue that is trapped fluid, and some people may see as trapped fluid, but the bottom line is a mucocele looks like trapped fluid. It looks like fluid because it is fluid on all imaging sequences. Look hard for expansion and destruction. If you're uncertain, follow it up. And that brings me to the last one, the cephalocele. The cephalocele is really more of a normal variant, but is associated with raised intracranial pressure. Cephalocele is the only one in this group that arises outside of the apex and does not arise from obstructed air cells. The cephalocele is basically protrusions of duroarachnoid from Meckel's cave that have been squeezed out of Meckel's cave and excavate or scallop the apex. And the reason they're squeezed out is because there's transmission of raised intracranial pressure to Meckel's cave. It's an entity that's more common in women, often associated with empty sella, and really it's not a true cephalocele in as we know them, in that there's no breach of the skull base, although there may be, but generally there isn't, and it just excavates the apex. Cephalocele usually bilateral, but maybe apical, as I said, more common in women, and it's associated with empty sella, and you can see it has a typical excavatory type pattern on the apex. Often looks like a little dog leg, you know, comes out Meckel's cave and bends back to excavate the apex. On CT, it's a low density mass, and it's associated, as I said, with non-invasive excavation. You see the sharp margin of transition between the cephalocele and the normal bone, and bilateral as it usually is because the pressure is transmitted both sides. In MR imaging, easy to diagnose, A, because of where it is, B, it's full of fluid, it's just CSF, so it follows CSF signal on all sequences and doesn't diffusion restrict because it is CSF as opposed to cholesteotoma, so that is the differentiator. So slightly different component, slightly different entity, but fits into this group centered on Meckel's cave rather than the apex. Remember, as with all the entities in this group, it doesn't enhance. So that's the one big group. The other big group is the solid lesions, which are really the neoplasms. And as opposed to the lesions that arise on the apex themselves, these arise outside of the apex and secondarily involve the apex. And that really makes diagnosis a bit easier because the first thing you do is try to characterize a lesion as you do with everything. The second thing, if you sort of guess where it comes from, knowing the anatomy, gives you a second clue of what it may be. So, you know, in other words, if something is following the path of a cranial nerve, there's a good chance it's going to be a schwannoma. And so that is another little bow in our armamentarium with solid lesions, which are an enormous list, but really the top four are important. Those are the chondroid lesions, the chordomas, the metastasis, meningioma, and maybe schwannomas lower down, and then a whole host of others. Beginning with the chondroid lesions, these arise from cartilaginous rests along the skull base, and particularly the skull base synchondroses, and that's why I highlighted that point in the beginning, particularly the petrooccipital fissure. The differentiation between benign and malignant is impossible in imaging, and so when we report these, we tend to call them chondroid lesions as opposed to chondrosarcoma, which is hard because you tend to normally just get so excited that you call it chondrosarcoma anyway. As I said, they arise in the fissures, so they usually parallel the line of the fissure. So the vast majority are sort of parallel the Petrous apex. But remember, up to almost a third can arise from the clivus. So position doesn't mean everything. As far as imaging, the hallmark differentiator here is going to be the chondroid type calcification, but there are a few other entities. So it parallels the plane of the Petrous apex. It's an expansile lobulated destructive mass with chondroid or popcorn type calcification. It's low signal intensity on T1, but it is markedly hyper-intense. So it's very bright on T2, and they enhance considerably. So expansile destructive, once again, quite a reasonable marker transition zone between the lesion and the apex. They tend to have all sorts of bony patterns, but very rarely are sclerotic. The sclerosis is actually in the popcorn calcification in the middle. MR is not bad for differentiating because you get this very bright T2 signal and they enhance avidly, usually more so than the chordomas, which are the entities which they get confused with. So, hallmark differentiator, popcorn calcification, parallel in the feature, and T2 hyperintensity with avid enhancement. Chordomas, as we know, can arise anywhere from the skull base to the sacrum. They arise from primitive notochordal remnants, and in the skull base region, they usually arrive centrally in the clivus, but may spread laterally to involve the Petrous apex. They often have this mount in the coronal plane, Mount Fuji type appearance, where they spread laterally to involve the apex. CT, a bit non-specific, locally destructive, centered on the clivus. And if you look at that lesion, you've got a lesion centered on the clivus. It's impossible on that to say, is it, could it be metastatic? Could it be lymphoma? Could be any of those things. But the position is really what starts to give us a clue as to what it is. These are also markedly hyperintense, in fact, more so than any of the other lesions here. But it's hard to say what's bright and what's very bright. But at least we know they're bright on T2. And then they have variable enhancement, less so than the chondroid lesions. And they're often supposed to have this honeycomb type of pattern of enhancement, which I must admit I've seen pretty rarely or infrequently. Not that we've seen too many of these. So central position is important. Remember, the CT could be anything, but it just illustrates what it may be rather than what it is. Very bright on T2. Soft tissue outside the apex, and then variable enhancement. Metastases are easy to diagnose, but usually there's a clinical scenario that's going to give you clues. They're in older patients who often have a known malignancy of breast, lung, prostate, or kidney as the most common. The Petrous apex is in fact the most common site for metastatic disease to the temporal bone, and the spread could be by all of the known routes. The imaging is non-specific, so I think you just got to be aware of clinical scenario. But like metastases elsewhere, there tends to be a destructive entity with avid enhancement, and it just comes into the differential, as we know. But as I've shown, these tend to arise outside the apex, spread to involve the apex secondarily, as most neoplasms do. Meningioma, also typical imaging features, and they tend to be either petroclinoid, involving the anterior aspect of the apex, or the cerebellopontine, involving the posteromedial aspect. And they have the typical imaging appearance of meningiomas, which I'm not going to label, but you can see the bony change on the bony windows. And if you look carefully on that, there is a little subtle soft tissue component brought out obviously with administration of contrast. On MR, you can see a little lesion within Meckel's cave, ducking under the petroclinoid ligament with a big cerebellopontine angle component, enhancement, dural tail. So typical imaging features, but just to be aware that they come into the differential. Schwannomas, as I've said, we know the cranial nerves around the apex, and schwannomas can arise from any of these. And the important thing is identify, could it be related to a nerve? And if so, could it be a schwannoma? And they too have fairly imaging features, which are pretty straightforward when they're small, but when they're big, can be difficult. But just remember where they are. In other words, where are they in relation to the apex? Could they be arising from a nerve? Posterior inferior, occasionally vestibular schwannoma can involve the apex, and there's a typical scalloped internal auditory canal with a large IC cerebellopontine angle acoustic or vestibular schwannoma, and occasionally they can be big enough to involve the apex. But the whole point about all of this is that they follow the expected course of the cranial nerve. So when you're looking at lesions involving the apex, just stop and think, could it be a schwannoma coming off? No matter how bizarre it looks, could it be a schwannoma arising off an expected position of the nerve? The imaging features are, as you know, and they solid masses, avid and heterogeneous enhancement, and variable T1, T2 signal. And then there's a whole host of others. These are paragangliomas, glomus, tumors can occasionally come up and involve the apex. Big one, and Andy's spoken extensively about neoplasm. Always remember nasopharyngeal carcinoma coming up, and we've certainly seen cases lately that have actually come up directly along arterial routes and just evolved the apex, but nasopharyngeal is a big one, and any other entity that has a predilection for bone can go there. So there's a whole list of common solid lesions, but the first 5 are by far the most common in a rare group. Vascular lesions, as I said, is really there are other vascular lesions that can involve the apex, but for the purpose of this discussion, it's an aneurysm. And the only reason we mention aneurysm is to be aware of it. And the aneurysm usually is congenital, but can occasionally be post-inflammatory or traumatic. They're usually asymptomatic, usually discovered incidentally, and large and fusiform at the time of diagnosis. The diagnostic clue here is that the lesion is centered on and incorporates the carotid canal rather than displacing it. So it's centered on the artery, often easier on CT than MR, because the signal in MR can be a bit confusing. But on CT you get this fusiform dilatation of the carotid canal. MR, as I said, can have a complex appearance, but importantly, it's centered on and incorporates the canal. And you can see in MR, you can figure it out eventually, but the key to all of this is awareness of what it may be. And the awareness is that it's centered on the expected position of the carotid canal. Bone dysplasia is literally just to show them, and they're terrible pictures of each, but Paget's and fibrous dysplasia, not difficult diagnosis and really included for completeness sake. And that really is the talk about the incidental Petrous apex lesion. I just want to end off with Petrous apex infection, mainly because, once again, it's about awareness, but it's an important one to be aware of. And the first component is Petrous apicitis. In other words, infection or involvement of the Petrous apex by middle ear infection. And it usually results from spread of otomastoiditis to the apex via the pneumatized air cells. And it's very much like coalescent mastoiditis in that you first get infection in the apex, it then tends to invade and destroy the epithelium and then gets to the bone. So you get this bony destruction, and then you open up the marrow, and there's potential for marrow involvement and potential for intracranial involvement, and you get into the whole Petrous otomastoiditis, skull base osteomyelitis complex. But it starts off as pure infection of the apex. The clinical presentation is variable. Usually patient presents with a discharge in ear and severe otalgia or facial pain. And the classical Granuloma syndrome is rare. You generally don't get it, but you can have the whole mix of cranial nerves and discharge in ear and pain. And I think, and probably the most significant clinical clue is the pain. And it's all about awareness. When we image it, we want to decide the patients deteriorate and they get in sick. Could they have infection of the apex? And the signs are hard. On CT, you get a pacification of the apex with otomastoiditis. You get middle ear mastoid opacification, you get a pacification of the mastoid. The first clue is that the apex may be mildly expanded on CT. I think that's a hard call at the best of times. And the hallmark is this permeative bony destruction, as you get with skull base osteomyelitis. The problem is you need about 30 to 50% of bone loss before you see that, so it's rare. But I think if someone is unwell and you see middle ear opacification, you see fluid in the apex, think hard about it, and recommend MR. And MR, the hallmark, I think, is going to be enhancement. You do get marrow replacement if you're starting to get bone marrow involvement, but really if the apex enhances, or even the apical region enhances in the setting of someone with bad ear infection, I think be aware of it. And that then brings us to the complications. So you can certainly then head on to Petrous osteomyelitis. The infection can spread to the margins of the Petrous carotid, and you get arteritis. You can get occlusion of the ICA, you can get aneurysm of the ICA. Venous thrombosis, we know well with skull base infection, and I think it's important any skull base infection or any suspected skull base infection, just look hard at the veins. And then you get your intracranial complications of meningitis, encephalitis, and brain abscess. And then Petrous osteomyelitis, just to come back to that, as I said, it can develop from Petrous apicitis, but can also occur in the non-pneumatized apex, and we see that commonly in malignant otitis externa. Once again, CT is quite hard to make the diagnosis, and you might see some soft tissue in the external auditory canal, loss of normal fat planes below the skull base. And then they talk about bony change of osteolysis and fragmentation. And they are, once again, hard. They're hard to pick up on CT. I think the easier one to pick up is the change in the skull-based soft tissues. If you see alteration in skull-based soft tissues, I think at least think about osteomyelitis. On MR, you see marrow replacement. So you see the normal fatty marrow becoming grey, and I think that's a very useful finding. If you see that, look on the T2s, it gets bright, and then you look at your post-GADs and see if it enhances. But the last point there, there's soft tissue involved in both above and below the skull base. I think that's really what we want to look at. Here you can see an apex that looks pretty normal, a little bit of stuff in the ear, but if you look at the fat planes on that side, they're just a bit greyed out as opposed to sharper fat planes on this side. And that, I think, is the clue. I think it actually was the same patient down the line. And you can see the middle ear pacification, you can see the apical enhancement, and in this patient it's gone on to Petrous osteomyelitis. So that really is the whole spectrum of Petrous apex entities. I think from an apical infection point of view, that's really what we're talking about. It's more about awareness. But when you go back to the group as a whole, as I said somewhere along the way, they're rare lesions. So we counter them infrequently. But when we do, because the apex is clinically inaccessible and because it's such a difficult place to get to, we really need to get it right, and that is to decide, is it a real lesion, is it a lesion that can be left alone, and that's the starting point. Thereafter, your clinical setting may add value in the setting of metastatic disease and infection, and if it's not one of those, I think we should just try to characterize it based on its appearance and its site of origin. Thanks very much.